Assalamu alaikum. Respected chairperson, distinguished panelists, all moderator and all participant, a very good morning to you all. I am Dr. Esmat Ara from Department of Cardiology, National Heart Foundation Hospital, now going to present in hospital short and long-term clinical and echocardiographic outcome in patient with mitral stenosis treated with percutaneous transvenous mitral commissurotomy. The incidence and prevalence of chronic rheumatic heart disease has decreased in the developed world, but is still prevalent in the developing countries. In 2005, more than 2.4 million children between 5 to 14 years were having rheumatic heart disease globally. Among them, 79% of these patients were from less developed countries like Bangladesh. Community prevalence was first reported in 1976, which was 7.5 per thousand in general population. A community-based study was done to determine the prevalence, which found 1.2 per thousand for rheumatic fever defined by revised Jones criteria, 1.3 per thousand for Doppler echo confirmed rheumatic heart disease. As most of the previous studies are retrospective, they provided limited information regarding clinical and echocardiographic improvement of patient after PTMC. So we have designed this study prospectively to assess the clinical and echocardiographic outcome to provide more accurate information. Our objective was to assess immediate in-hospital, short and long-term outcome of PTMC. We also wanted to assess mitral valve area changes, hemodynamic data including peak and mean gradient PA pressure and LA pressure before and after PTMC, also to evaluate clinical symptom and cardiac functional status of the study population, and clinical events including congestive heart failure, arrhythmia, and appearance of thromboembolism. We have included patient with severe mitral stenosis of rheumatic origin with valve area less than 1.5 square centimeter, patient with restenosis after previous PTMC or CMC, age less than 65 years, and patient with mitral stenosis valve area more than 1.5 square centimeter, mitral regurgitation grade 2 or more, LA thrombus Wilkins score more than 10, patient with other valvular disease or coronary artery disease, contraindication to septal puncture, and patient with significant other comorbidities were excluded from the study. It was a single-center prospective observational study conducted at the Department of Cardiology, National Heart Foundation Hospital and Research Institute. Started from November 2019, 195 patients so far have been studied. They divided into two groups based on Wilkins score. Score 8 or less was group 1, and group 2 patient had a score more than 8. Successful PTMC was defined as either mitral valve area more than 1.5 square centimeter or area of more than twice the pre-procedural value, complete opening of at least one commissure, together with mitral regurgitation not more than grade 2, 50 to 60% reduction in transmitral gradient. Symptomatic improvement was defined NYHA class 1 or more functional class dyspnea reduction. Mean age of the study population was 36.57 plus minus 9.33 years. There was female preponderance, female to male ratio was 6:1. Group 1, 139 patient had score 8 or less, and group 2 patient had who had score more than 8 was 56. This table shows the baseline characteristics of the study population between two groups. Total 184 patients were successfully underwent PTMC, and PTMC failed in 11 patients. This table shows the variation in echocardiographic variable between two groups before and after PTMC. There is significant increase in mitral valve area and reduction of mean and peak gradient PA pressure and LA pressure, a greater achievement in the group 1 patient. 4 patients developed cardiac tamponade, 5 patients developed severe mitral regurgitation and acute left ventricular failure, 3 patients developed arrhythmia, 4 died, and 2 patients required MVR. A greater proportion of our patients relieved from dyspnea and palpitation, and 20 patients reverted to sinus rhythm. 20 patients did not respond to follow-up. The rest of the patient, up to 2 years follow-up shows there is gradual reduction in valve area, but there was no restenosis, and there is gradual increase in mean and peak gradient, which is more evident in group 2 patient. So our post-PTMC data shows there was significant echocardiographic and clinical improvement among our study population. Most of the population were young women. This may be the reason of good results and higher success rate. Group 1 patient achieved more valve area and greater reduction in gradients, LA pressure and PA pressure than Group 2 patient. 2 years follow-up shows gradual loss of valve area, but no restenosis was reported. The results obtained from our study prove PTMC is a very valuable procedure in this era when rheumatic heart disease is still prevalent among the developing countries. But it was a single center study, small sample size, and a mean age of the study population was rather low compared to those reported previously. Echocardiography was done by different echocardiographers. So it is likely that differences in scoring occurred among different investigators. Thank you.